We're going to talk about PSA screening, and we're going to talk about prostate cancer screening tonight. And that's been an incredible moving target over my career and over the last many years, and it's very confusing for people. And the reality of the situation is, at least my patients, most of you are probably my patients. Some of you might not be my patients. But the reality of the situation is that I tend to do things I have found differently than a lot of other urologists. And so I have a webinar series on my site, which is, you'll see it on the slides, dcurology.net. And I plan to add more and more topics to that collection of webinars, but I thought that this was a topic that really sorely needed to be discussed in terms of all the different tests that are out there, and MRI and the usage of it. And I don't use it that much, and it gives me a chance a little bit to explain why. And we'll see if some of you come to the same conclusions that I've come to over the years in terms of doing PSA screening and prostate cancer screening the way I do it. This is, my opening slide. It's a little bit different than the title you may have seen on your invitation, but the key here that I wanted to change the title to is to understand that this is kind of how we do it in 2023. This is how I believe we should be doing it in 2023. But more importantly, this is how I do it. I have found, I've treated so many prostate cancer patients over my career, and I certainly dealt with the issue of elevated PSA so much. I feel as if how I do it tends to be a little bit different, or sometimes a lot different than how some other urologists do it. So I'll put that asterisk next to this talk. This is how I do it. Doesn't mean how other people do it is wrong. Let's see what you think by the end of the talk. I tried to just start this with just a little bit of a summary as to what we're going to be going through, and I'm going to try to abbreviate this so we're not talking for too long, but it's a long history. I'm going to introduce to you what PSA is, when it was introduced, how it was used at first, and how we knew it wasn't really a great test at first, and some of the mistakes that we made, but ultimately take you through from it being a very poor, malign test to it being actually a fantastic test as long as it's used correctly. In this history, and so what you're seeing here is a guideline, is a timeline basically of history. We go from PSA testing saying there's a one-size-fits-all situation to PSA testing and a lot of tests being created to give a sense as to, can we make the PSA test more specific to not do so many unnecessary biopsies? And then we need to know about this new concept that had been introduced, that we don't really need to find or treat all cases of prostate cancer, only the ones that are going to be harmful to you. We wouldn't be able to give a good prostate cancer talk without talking about what changed, when there was that whole debate over Obamacare and what that led to in terms of guideline changes, and how that was sort of a detrimental effect on society. And then carrying it to when the guidelines were changed back to using PSA, and the thrust of new tests that everyone always has questions about with regards to only looking for cancers that are going to be more aggressive. You might get a sense here, look at all these different tests that were created. Hopefully you're getting a sense that there's a business to this, an industry to this. And then we need to talk about the introduction of prostate MRI. That just seems like a ubiquitous thing these days. It's something I don't use as much as the next urologist, but where was it first introduced? Where was it first studied with very high quality research, et cetera? And then we're going to say, how did it become a primary screening tool? And what can we learn from it? What are its good sides and what are its bad sides? And in my opinion, in a lot of ways, using MRI as a primary screening tool has not been a very good advancement. And then we're going to talk about PSA as a trend test. This is what's caused it to be a fantastic test. And the question really, and the two different philosophies are you going to screen people with MRI, or are you going to stick to using PSA as a trend test? I'm going to be someone that sticks to using PSA as a trend test. And then at the very end, we'll just talk about some different biopsies to clear up some of that confusion. I do them all, and I'm explaining it. And we'll summarize with just some of the basic tenets that I use in my practice to who do I biopsy. So let's talk about PSA, and let's talk about, when was it introduced? It was first introduced in 1987, and it was introduced really as It's a molecule. PSA stands for prostate specific antigen. It's an enzyme that's in a man's semen, and it's made by the prostate. That's why it's prostate specific. And we know that this enzyme has the function of liquefying semen. So the semen that you shoot out is more liquidy than the semen that comes out of your body initially, and that aids fertility. And that's pretty much all we know about it. It's not a regulated substance, and there's lots of things that make it go up and down that aren't cancer, and we'll talk about that. But the initial introduction was based on a very small pilot study. It was something like 150 patients, where it said, hey, we got this thing that can identify cancer, and for not really any good reason, 4.0 was used as the cutoff to say above that you're abnormal and below that you're normal. And that's kind of how we did it for a very long time. That's how we did it at my training at Northwestern. It's how we did it in the first 10 years of my practice. And we know that to have just been absolutely wrong. So that's an important thing. But that's how it hit the scenes. Early 90s is when it was used for screening. It was something that, it was very well timed, because that's when ultrasound was created. And so now we had easy ways to do biopsy. So you had this test that was culling everyone out of society, and everyone could get a biopsy. And suddenly it was a new problem. Prostate cancer wasn't new. It's always been a killer in men. It's the #2 cancer killer in men. But it created this whole question of, what do we do with all these guys we're finding that have these little bits of low-grade, little bits of prostate cancer? And the answer in the beginning was treat them all. It was such a new thing that a new grading scale had to be created called the Gleason score. But what happened is, as we went crazy, this is what put Hopkins on the map, is every faculty member there immediately was a prostate cancer expert, because the volume was so high, and an open radical prostatectomy was popularized. But as the data was coming out, there was really very little decrease in mortality. It wasn't clear that we were helping our society this way. And Europe was very slow, actually, because they are very much based in evidence-based medicine. They were very slow to adopt PSA for that reason. And so there were many, many men being treated, but it wasn't entirely clear that we were helping people. We were making the assumption that every little small case of prostate cancer would eventually become the type that we were used to seeing, which is the one where we would see them in an end-stage situation. So everyone was treated. So every case used to be treated as if it would save a life, but the data really didn't support that. So from very early on, people were sort of smelling a rat with regards to PSA. Something's not really, right here, that kind of thing. But the data and the massive amount of research that went into PSA and our American treatment of this screening program, it came up with some conclusions which really were faulty conclusions. One thing that every resident, everyone used to know were the Parton tables. Dr. Parton was a staff member at Hopkins, and since became the chairman and passed away unfortunately at an early age. But this was one of the first bits of research that really stuck, which was looking at the Hopkins database and getting a sense that if you had certain pathologic parameters, you did worse. So there was this tendency, particularly at Johns Hopkins, to treat lower grade patients because the Parton table suggested that you were doing better that way. We know now that what the actual conclusion was is that small, low risk disease was something that didn't harm anyone. So of course you did well there. And that actually it was the opposite conclusion that should have been reached. Back then it was, you're at higher risk of failure, so let's not do surgery and let's do radiation. Now it would be, you're the exact person to have surgery for. But that was one place we went wrong. And since most of the cases back then, because we were biopsying at such a low number, were low risk, that you can imagine the number of patients that were overtreated and overdiagnosed back then. So that was lending itself to being poor for society. The treatments that we had hadn't really developed so much, so they were very morbid. The radiation that was done was that it would radiate your whole pelvis and have a lot of side effects and wouldn't work. And what really put Hopkins on the map is that the chairman there named Patrick Walsh had described a new way to do that surgery through an incision. And anyone that was a resident of that era just did hundreds and hundreds of those operations, myself included. The idea is that the nerves for erection could be spared. And so now this is great. We're catching everyone and we can do this magic operation and save their erections, when in reality, the outcomes that were reported were very unrealistic. And that, you know, this place would have these unbelievable numbers, and this place would say that everyone had, you know, poor erections, and a lot of marketing got involved in this. So things kind of went out of control with overtreatment. There was even the point where a pioneer in our field, who was at Washington University in St. Louis and eventually went to my alma mater, Northwestern, Bill Catalona, actually suggested that maybe we should even lower that cutoff to 2.5, and that was accepted for a long time. So people with a PSA of 2.6 were being biopsied, and any of you that's in my practice now can hear how different that is than the advice that I've been giving you recently. There was a push towards making treatments that were easier and theoretically less invasive. And then there were the concepts of, we'll take this low risk disease, which we didn't know didn't harm anyone, and we'll maybe just zap a certain area. We'll do these minimally invasive procedures in the Cayman Islands, et cetera. And that's what HIFU was. So these were kind of the cowboy days of this, because I call it navigating without a compass. We really didn't know the disease, but we were treating everyone at that time. The meetings were always the hallmark papers being presented. The ones that are being presented in front of 500 people at a national meeting would be the ones looking at mortality rates. Are we helping our society? With the Europeans saying no, and us saying yes, 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 maybe because it's fee for service, maybe not. And so there was commonly this idea that something's not right here. We shouldn't be biopsying all these people. For every biopsy that was positive, there were maybe 5 that were negative back then, or 4 that were negative back then. So what happened was there was much research done. It wasn't like urologists were just trying to do this wrong. This was absolutely the focus of urologic research. And what was shown very early on, the hallmark paper being at Columbia University, was that the rate of rise, that if you followed a guy over 2 years, that if they had a sustained, consistent rise over 2 years, that's what tended to predict real prostate cancer. So this was a big term, PSA velocity. In essence, that's what I do now, a trend test. These were the initial thoughts of, let's do it that way. The problem is that got taken out of context, and then people with PSAs that were rising within the normal range were getting biopsied. If it was over 0.75 a year, so a rise from 1 to 1.8 maybe got biopsied. We understood kind of what was going on, but not entirely. PSA density divided the size of your prostate with PSA. In other words, people started to realize, look, if you have a big prostate for benign reasons, and I have a lot of webinars on my website about BPH, that you're allowed to have a higher PSA. So people created a density score to determine, do you need a biopsy or not with an elevation? And then it was very much understood that the older you are, the higher the PSA you should allow. So 4 was for young guys, and then it was 5 and 5.5 and 6. Really, again, that was just understanding that your prostate grows as you get older. My patients have heard me say that, and that a normal rise is simply normal. So we understood this early on, and those were observations. They were actually industry-based tests created to also try to say, okay, you have an elevated PSA of 5, let's figure out if that's a suspicious elevation or a non-suspicious elevation. So again, all of these tests that you see listed here were tests that were based on single data point usage of PSA, meaning your PSA is 5, we need to make a decision right now. Do you need a biopsy right now? And let's get a second test. I call them adjunctive tests to see. Free fraction is one of them. I don't use it very commonly because only the extremes give us any information. The complex PSA is the opposite of free fraction, and for a while people were trying to popularize that as a separate patented test. The PCA3 was the first foray into using a specific gene, looking for a genetic product to say you're at higher risk of having prostate cancer. That one required a hard rectal exam, and then you'd have to urinate some of your prostate fluid out. So you can imagine patients weren't a fan of that. Prostate Health Index was then fomented when when more and more researchers were finding genes that maybe had, or gene products or certain isoforms of PSA or proteins that may be a little more predictive. And that's something that Hopkins and other academic places popularized based on this form of PSA they call P2 PSA. But none of these tests predict whether the cancer that is found would harm you or not. So this would tell you, is cancer present? But it wouldn't tell you the real question that we asked today, which is, do you have a significant cancer, one that we have to worry about? And that's what it's all about today. So, but these are just evidences that we understood very early on that PSA needs to be better, and we have to figure out ways to make it more specific to avoid so many unnecessary biopsies. And then, so that's one of the things that changed that paradigm a bit. The other thing that changed that paradigm a bit, and I would say most of us urologists would credit someone named Valentine Carter at Johns Hopkins to actually have come out with this concept that not all prostate cancer patients need to be treated. And that was a heresy. That was a very revolutionary concept that he should very much get credit for. To introduce the concept that we're going to watch you. We're going to do active surveillance. These two terms are terms that we would see very much in the prostate cancer world, so they're worth talking about. They mean different things, though. At the time when people were using watchful waiting, it was the initial thought that, you know, if you're not old, if you're old enough, if you don't have a long enough life expectancy, you'd be better off just not treating the prostate cancer. And if it's a slow growing one, the concept is we're just going to watch you and we'll help you with hormone therapy down the line, not cure you, if you ever get to a point where you need it. So we're going to watch you and we're going to wait for trouble. The idea with watchful waiting is it's a bit of a gamble, and you win if you die before you know you have prostate cancer. That's what watchful waiting was. Active surveillance, which is what Dr. Carter put forth, is very different. It's saying, we see you have prostate cancer, but we don't have enough evidence that it's growing. And at the end of the day, we need to see that it's growing before we offer you treatment. And that's the key. Remember I said this, he was looking for cancer that was growing. Part of that was, we're not going to treat you. And it went from 10-year life expectancy to 15-year life expectancy. And we started talking about significant cancers versus non-significant prostate cancers. And really, even today, anyone who's been counseled in my practice about prostate cancer understands that I take this very seriously. And the first thing we have to do as partners together is to determine, do you need to be treated or should I be following you? That's what active surveillance is. So then we started to see in this period of time, we're getting closer to the present, an evolution of tests. And these tend to be very expensive tests because they're genetic tests. They're not always covered by insurance, that we're now not just trying to tell us, is it a more suspicious elevation or not? Are you more or less likely to have cancer? But more so, are you more or less likely to have what we call significant cancer, more aggressive cancer? The biomarkers of the genes they're looking for are usually just cell growth genes, so they're saying the same thing. Probably the most common one that we see is called the 4K score. And then there's some others. The first introduction was called Select MDX. A more recent discussion is called ExoDX, and they like to market themselves as a liquid biopsy. We can tell you if you have cancer without a biopsy. It's really not true at all. It's a marketing point. Those that are using these for the right reasons, I think, get them because they're trying to show that it's very low risk. When a patient sees that there's an elevation, this would hopefully say it's low risk, it's okay, we can follow you. Now, of course, any of my patients know I don't need those tests to know that. I'm going to follow you either way based on the situation. And I'm going to let the PSA trend tell me. But these are marketed tests. And so there are some urologists that would like to have that reinforcement to know that it's okay to follow you. The problem with these tests is a suspicious number might say that you have a 9% chance of having a significant prostate cancer. And that, I just simply don't find that helpful. And the problem is, if a patient's very nervous, hearing 9% just makes them more nervous, whereas I already know there's 9%. But my concept in my practice is, and if you have that significant cancer, your next PSA will be higher. And therefore, why don't we just check your next PSA? So I've tried all of these tests. I actually did a major trial of Select MDX, and I found that it actually never changed my management in any way to what I would tell patients. And I only found that there was much more anxiety and patients asking for biopsies when they didn't need them when I was using these. So, but the key here is now we're having a push towards saying we're looking for significant cancers. That's it. But the problem with these tests, and we're going to talk about this with MRI, is that they really only are going to find very aggressive cancers. So they're only going to find the highest Gleason scores. If you don't know what a Gleason score is, cancers all get graded with a score. And really, there's 4 scores of prostate cancer. And many cancers have either 3 or 4, be it breast or whatever cancer you'd like to substitute. And these are only going to find the most aggressive. So that's the grade 3 groups or the grade 4 groups. Now that means you'd have, if you believe in these tests, and this is going to come true with MRI, you would have to completely agree that there are no cancers in these smaller groups that are worth finding. You would have to absolutely subscribe to that belief. And we'll talk about that later. So these tests only find, and they admit, they only find higher grade cancers. Doesn't tell you anything if a patient has cancer and it's lower risk. Now we're getting closer to the present because Obama was our president not that long ago. It seems like a long time ago. But the idea with this is that some of you might remember that argument over this, and when it was legislated, and one of the ways it got passed is to say it's going to save money based on evidence-based medicine. In other words, and it's a good ideal. It's a very good ideal. It's the fundamental tenet of socialized medicine. We're not going to just pay for a treatment unless it can prove with evidence that it's helping society. And you already heard me say, if you were to look at PSA and put your blinders on and say, we're going to look how PSA was working from the beginning, you would have to come to the conclusion that PSA was not helping society. There was a report, and that's what it's called, the U.S. Preventative Services Task Force report from the government, looked at all the screening tests. And it, of course, had to look at old data, and it showed the data, the performance of PSA as a single data point test. And of every test, mammogram was a close second, but of every test, PSA was the worst in terms of you have to screen this many people to catch one case, to save one life. And so they created that ratio. Back when they were doing Obamacare, they were test marketing society to see would they accept this concept of not screening our population. That you might remember them talking about not doing mammograms for women below 40. That was another one where it was not helpful, and society rejected that. So, but the idea is when they were talking about evidence-based medicine, they clearly had PSA very much in their sights, and they did go after PSA and created a huge PR campaign against PSA. And I know this because I had been interviewed several times for the New York Times, and I know that I was actually on NPR where they were trying to get me to say PSA was a terrible test. I'm not sure I said what they wanted me to say, but that actually lent itself to there being pressure. All of these statements are true, and when you use PSA as a single data point test, it's terrible. You should never make a decision on a biopsy based on a single point. And that caused the AMA and most others, with some pressure from the government, to change their recommendations and their guidelines against PSA testing. So we actually went through a period of time in this country where the guidelines stated, do not test with PSA. That was a period of time where I saw many people showing up with end-stage advanced prostate cancer because of that recommendation. Doctors were doing the right thing. But the problem was, and this is my bias against kind of inserting politics into this, is that this wasn't a new concept back then. All of our data, all of the papers being presented at meetings, New England Journal papers showed that if you don't use it as a single point, but if you use it as a trend and you only base your biopsy decisions on a trend, then it actually went from being the worst test on the list to being perhaps the best test of all screening tests. Problem is, it's not easy to regulate. It means you can't say that we're not going to screen Medicare recipients. It just means Probably a better approach here wouldn't have been changing the guidelines, but just pushing education and making sure that this last line here is an important thing. And I pride myself on trying to make my patients my partners, but it should be a shared decision making. In other words, let's talk about it together. Let me teach you about PSA, and let's see if we can come to the conclusion together as to whether you need a biopsy. The trend test by far is the best way to differentiate, way better than those previous tests I mentioned. The difference between dormant cancer that doesn't need to be treated and aggressive cancer that does. It's just obvious. All of our data shows it. It's just there's no one pushing for a test. There's not much money to be made in this message, but all the data is out there. The best way to avoid unnecessary biopsies is not to overscreen people and to say, let's see what the next one shows. I'm hoping some of you have been saved from a biopsy because I've been following you and we showed that your PSA normalized. In my practice, what I do, I've introduced to you what active surveillance is. That's going to be, we biopsied you, but we found such a small amount of cancer. We're not saying it's growing. We don't have any evidence that it's growing. In other words, what I do in my practice is I do active surveillance without a biopsy. I'll see a patient. I do it all day long. It's probably the most common thing that I see. And it will be a patient that has an elevated PSA. Let's call it 6. For me, if that 6 is truly elevated because he has a little low-grade prostate cancer, I know if I treat him and that's all I find, I'm just going to follow that person. I'm going to say that's not enough for me. I'm going to follow you and check your PSA at a certain interval. So why not just skip the biopsy, pretend you have it in our mind, and see what the next one shows? Therefore, many patients skip a biopsy, and they're going to skip the anxiety associated with now knowing they have a little bit of cancer. That's not easy for some people to know and sit on. And I'm going to keep my patients from being overtreated and over biopsy by doing this concept. So that's really the hallmark. And the way I do it with just checking PSAs, of course, is by far the least expensive approach. It's therefore the least marketed approach. So now we need to talk about MRI and prostate MRI. And this is really an area of controversy probably within my practice. So I'll just tell you the world according to me with regards to prostate MRI. Prostate MRI was introduced because there was this technology, and it's gotten even better. How good an MRI is has to do with how good the magnet is. Believe it or not, the unit of magnetism is the Tesla. It's not just a car. Here's a new technology, and right about when that technology was introduced, it's right about when Valentine Carter was starting to tell everybody, hey, everybody, we don't need to treat all these people. We need to follow them very closely. Now, Valentine Carter used to sign people up for a research study because he was being a pioneer and he had to keep a close eye on them. But he was biopsying people every 3 months or every 6 months forever. And that's not a very tenable situation, especially because, back then biopsies used to carry with them a significant infection risk that doesn't exist to the same degree now. So the MRI was introduced to be this great way to potentially follow patients that are doing active surveillance so that they don't need the Valentine Carter 3-month or 6-month biopsies for the rest of their life. And it was a very, very good goal. And the pioneers in seeing that and doing that were at NIH here, right here in Bethesda. So I'm very, very familiar with that. And Peter Pinto is the pioneer of that and very much to be commended for putting that on the map. A perfect MRI would be an MRI that would see cancer, a magic test that would see cancer. But what they're looking for in active surveillance is they're looking for progression. They're looking for it to get worse. They're trying to catch cancers that are progressing that then need to be treated. What they found is that it's a decent test, but again, just like the other ones, it's very poor unless you're talking about high Gleason scores, 4+3 or higher. That if the test is negative, it's pretty good at saying you don't have something super aggressive, but it's very poor at telling you if you have anything. And it tends to overcall things. It bases lesions on something called a PIRAD score. Not important to know what that stands for. It's very, very radiologist dependent. Those of you who are my patients will know that I insist you go to certain places where I know who the radiologist is. Some of you might be Dr. Losey's old patients. He used to screen everyone with MRI. And, certainly the percentage of MRIs that are positive coming out of Sibley is much, 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 much higher than the ones at MedStar, where I send people. So it's very, very radiologist dependent as to what they will call abnormalities. And on a later slide, I'm going to show you that even when they say it's abnormal, it's not as predictive as you might think. Now, what came out as a result of MRI coming out, and it is a great way to follow people in active surveillance, and it does keep us from doing that Valentine Carter program. And it is absolutely the thing to do if someone's already had a normal first biopsy in the office, and now the PSA keeps climbing. You have to do something else. You have to do a better biopsy. You have to look to see, am I missing something? And that's where the MRI fusion biopsy comes into my practice. But the MRI fusion biopsy, if done in someone's private surgery center or done in the office, is a much more lucrative biopsy. And so there is this tendency to overuse the MRI fusion biopsy. And we'll talk about that later, what that is. What I'm introducing to you, though, is a new technology that's come about right at the same time as another technology. And that kind of causes a symbiotic relationship to be used, somewhat overused. So in my practice, I use it for these two reasons: active surveillance, and I certainly always do a biopsy before I'm going to biopsy someone on active surveillance. So I need to see if I can add that biopsy. And I do it when the PSA keeps climbing in a very suspicious way, despite having a normal first biopsy. So that's when I'm a very big fan of the prostate MRI. Unfortunately, though, those pure ways to use it, those are the ways that are the guidelines of the American Urologic Association. Unfortunately, prostate MRI was so welcomed, certainly at big academic centers, and then it moved on. It was just so welcomed that there was so much research on it that it spilled out into initially becoming a primary screening test, and now for many, many urologists, it's their standard of care. It's what they do. So you remember when in the past you had a PSA of 5, you might get something like a free fraction. Then later on, you might get something called a 4K PSA for urologists to have a secondary test to see, are you okay? Unfortunately, in my opinion, now the prostate MRI has become that secondary adjunctive test. It's largely replaced those. And these are the things that I would say about that. There's a very poor correlation of when it's suspicious. So if you have the problem is, let me just go through this. So it goes up to 5, 1, 2, 3, 4, and 5. Everyone agrees 1 and 2 is nothing to worry about. A 3 shouldn't prompt a biopsy on its own. And it correlates to not all cancer, because remember, we only care about significant cancer. Cancer where you're going to have to be treated, it only correlates about 5% of the time. And when it's PIRADS 4, which means you're going to need a biopsy, it only correlates to a cancer that has to be treated roughly 20% of the time. You'll find lots of different reportings on this, but I'm talking now about cancers that you would have to treat. And then even the most suspicious is only 50 to 60% of the time it ends up being a cancer that has to be treated. So that means in our world, very, very poor sensitivity. Now, what that means is we've taught you now through a timeline here. We've talked about PSA. We were going without a compass. We didn't know what we were doing. It wasn't our fault. We started to learn. We need to make it more specific. And then every effort in our research world has been designed to limit an unnecessary biopsy, to only look for people that have to be looked for. The problem is when a patient asks for this, or if they get a PSA, and it comes back with a PIRADS 4 lesion, now you have the scarlet letter here, and you have to be biopsied. So in my practice, it's not a welcome thing to hear that someone's had a biopsy, because it takes a person that I otherwise maybe would have had a 20% chance of being biopsied in my practice, because I would have rid out that elevation. Aging causes the PSA to rise. I call it the plane, going to cruising altitude, and then it'll level out around 5 or so. If you're not going to allow that to occur, once you have a abnormal MRI, you're going to end up having a biopsy. If you have a biopsy, there's a chance you're going to find a cancer, but it's not significant. And now you're going to be off to the races with anxiety, etc. So I don't consider the MRI your friend. I do it for people that they really, really ask, but I say, be careful what you ask for, because if you ask me to do this biopsy and it's abnormal, I will have no choice to biopsy, and that is not in your best interest. If you look at these numbers, by the way, if the PSA elevation in the first place is from cancer, then what should the next one be? It should be, and if it's growing, it should be higher. It's that simple. So I would catch this, and I would catch this a couple months later when the PSA continued to climb. So I've been doing that for so many years. It's so clear to me that I think I'm helping my patients in doing that. It's why I've not been using the MRI as a primary screening test. I find it, again, to take us back in time to the days where we weren't necessarily helping society with our biopsy patterns. So it'll increase the biopsy rate in someone who's willing to check what the next one shows, not decrease it. So it decreases the threshold. And we've already talked about this. And again, it doesn't catch lower Gleason scores. So again, you'd have to very much believe, and there are many people in academia that will tell you, yeah, we don't worry about it unless it's a very high score. You know, so they'll say if it's negative, we're okay, because we know you don't have anything terrible. Again, I don't really need to know that. I'll find out if you have something bad with the next PSA. And most studies of MRI fusion biopsy alone show that just biopsying the lesion is completely inadequate and not good enough. So you end up with a regular biopsy anyway. And again, it's very expensive to society. It can be lucrative, and I wonder sometimes if that's related to its easy acceptance in our society. And this is a point that I've been hinting at. And here's the question: is a prostate cancer with a Gleason score that is less than 4+3? So one of these, or one of these. I don't know if you can see my fingers because it's small. So in other words, are we okay saying that every man is fine if they have lower grade cancer? And this is my answer. And I'm hoping I'm making that pretty clear. I've had so many cases of prostate cancer. I've done about 2,500 to 3,000 prostatectomies. And I lament the fact that certainly early in my career, there can be no question that I was overtreating some people based on false premises. I also know that you can't say that statement as a one-size-fits-all. I have plenty of patients who are metastatic with lower Gleason scores. I always say to patients, it's not so much about the Gleason score. The Gleason score predicts what train you have. Do you have a Japanese bullet train? Do you have the Acela? Do you have the Metroliner? Do you have a cargo train? But if you're 47 and if you have tons of Gleason 6 or 3+4, even the cargo train will reach the station eventually if you have long enough to live. So it's just not a scenario here that can be pigeonholed into a one-size-fits-all statement. It has to be a doctoring thing, the art of medicine thing. And people don't like that when they're setting guidelines, but the reality is it has to be that. And any of you have had a talk from me with regards to, you have prostate cancer. The first thing we do is we sit down and we talk about risk stratification. And we talk about all the elements that go into what I call the salad bowl to determine, where are you on the risk stratification scale? Are you really terrible? Are you nothing? And there are a lot of things that go into it. Gleason score is one of them, but your age, of course, your family history, of course, how much cancer is there on your biopsy? How suspiciously rising was your PSA? So if you have a 3+4 and you have 9 out of 12 needles positive and your PSA has gone from 3 to 5 to 7 to 9, and you're young, that train will reach the station. So it's not fair to say that we need a test that only catches aggressive things. But the PSA trend will catch if the cancer is growing, okay? So this is my statement. Growing cancer, if you're young enough, is significant, and dormant cancer is not. That, to me, is the statement, not this statement. And that's what active surveillance was based upon, and that's what using PSA as a trend test is based upon. So ultimately, let me see if I'm, yeah. So let's see. Well, that's pretty good. I was trying to stick to about 45 minutes. So ultimately, what are the take-home messages of how do I do it? And maybe I'm not trying to convince everyone that I'm better than anyone, but this is the world as I know it. I've tried every one of these tests. I've read almost every paper on prostate MRI. And this is how I've evolved. I use PSA absolutely as a trend test. It's very rare for me to offer someone a biopsy when I first meet them. There are many great internists that will already be using it that way. So when someone's produced to me, they already have 3 or 4 in a row. But I very much tell my patients, it's very normal to have a PSA slowly creeping up, but it's just like an air traffic controller. They're going to say, go to 30,000 feet. They're going to watch that PSA rise. And then maybe it misses some clouds. And so many of you must be familiar with this is what I do. I've been doing this so long. I'm looking for a trend on a graph. I don't need any adjunctive test to tell me, is this one point abnormal or abnormal? It just doesn't help me at all. If the plane keeps going, the air traffic controller is going to wonder, there's something wrong here. The computers will tell in a minute, there's something weird here. That's the guy I'm going to biopsy, okay? These are some, I put some quotes here because these are some things I say to patients. So what I'm doing now, as opposed to what was done when I first started practice or even 10 years ago, I'm on a fishing trip. I'm hunting for tuna. That's what I want. If I had a perfect situation, I'd have a bait in a situation where no other fish would grab my bait. That's what I'm looking for. And if you do this enough, you'll see that the trend is going to tell you when there's a tuna on the line versus something else. Just like any of you have ever been on a fishing trip, the captain knows what fish is on the line by how it's pulling. So I was talking to someone today who, was very nervous about their PSA rise from 1.7 to 2.0 or 2.1. And I explained to them the type of rise I'm going to need to see to be worried would be 2.0, 3.3, 4.1, 5.4. It's that kind of damning result that's not for sure that that guy has prostate cancer, but it means if I catch prostate cancer with that rise, that's a significant cancer and it's likely to need to be treated regardless of Gleason score if they're young enough. So therefore, there is no set single PSA threshold. I have many patients I'm following with PSAs that are 20, 18, 15. Yes, I've biopsied them. I've done a better biopsy, which is on the next slide, to get me to the point where I'm comfortable following them. But there's no single threshold. There's trends that get me upset. The first biopsy that a person will be offered, let's go over here. So we talked about the concept of active surveillance before the biopsy. That means I'm going to demand to see a suspicious trend. We talked about the fact that I'm always going to weigh into, in essence, what do I think your life expectancy is? And that's going to very much change. What is your age? It very much changes the point at which I might offer a biopsy. So again, there's no singular answer. I'm interested to see if I get this question in the Q&A as to who gets a biopsy and who doesn't. It's a doctoring thing. It's a partnering with my patient thing. There can't be a specific guideline. That's why I'm doing this talk, actually, because it's hard to just write who gets a biopsy and who doesn't. When someone's particularly elderly, and I saw many of my old partners' patients who still had a fair amount of anxiety. They might be 83 and their PSA was 6.2. And I explained to them there's a point at which, the guidelines would say stop getting PSA if you're older. And you don't necessarily need to do that. You just need to understand PSA and understand that no one should be biopsying you when you're in your 80s, greater than 80, 81. Unless your PSA is close to 20, because in that age group, it's not wrong to use PSA, but it's really wrong to overreact to PSA. What we're going to do in that circumstance is say, look, you're 80 something. It's no problem if we leave your prostate cancer there, even if it spreads, it's no problem. We usually pick an arbitrary number of around 20 to say above 20, we might treat you a little bit for it. It's not going to be a big deal. So a lot of older patients in my practice have heard me say, we're just going to follow you until it gets to 20. The first biopsy in my practice that's always done is an old-fashioned transrectal biopsy. There was a day, and I certainly lived through this day, where sepsis after a biopsy was not rare at all. Most of the reports that kind of all came out when the guidelines changed were very much inflated. I used to quote something like 0.3%, but when it happened, it was a big deal. And it all came about because we and other doctors used to overuse a drug called Cipro and Levaquin. And so we selected out for a form of E. coli that was particularly virulent and resistant to all the antibiotics we give you. Now that we don't use Cipro and Levaquin much anymore, I haven't personally seen an infection after a prostate biopsy of sepsis for 4 or 5 years. So it's something that's such a small amount. I warn my patients about it, but it's by far the easiest, simplest thing to do first. But ultimately, I already talked about who do I get an MRI on. This is where I use MRI, active surveillance, and when the first biopsy is negative. And what do I do if the PSA keeps rising and I need to do a better biopsy? This is why I threw this slide. These are the biopsies that are typically done. There are very few people around that do saturation biopsies, but the saturation biopsy in every recorded paper has always been shown to be by far, when it's done the right way, which is an old-fashioned way, it is by far the most sensitive way to do this. By far, it's just that logistically, it's hard to do in a surgery center. It pays very, 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 very little, and therefore it's not popularized, but it's transperineal, meaning it's through the skin under your scrotum. The infection risk is very, very low. But this is the hallmark of what I do when I need to know for sure what's going on. I add to it something called an MRI fusion biopsy, but in reality, the MRI fusion biopsy is not even close to the saturation biopsy in terms of its sensitivity. I do it because when I'm doing this type of biopsy, I want it to be your last biopsy, so I'm going to do everything I can to get that done. Lucrative when done in the office. I don't do it that way. I do it transperineal. It should be done transperineally. But you can only do it if you see a lesion on the MRI. And I have a series now of about 200 patients, and I'm going to write this paper up with the pre-meds in my office this year, where I already know the conclusion. There was never one time where I did a saturation and an MRI fusion biopsy where the MRI biopsy found something and the saturation biopsy missed it. But there were plenty of times where the saturation biopsy found it and the MRI fusion biopsy missed it. So I might even, if I get that published, stop doing an MRI as a screening test as an unnecessary step. So that's a lot of talking, and it's about 45 minutes, which was my goal. We have a lot of questions here, and this is the fun part for me. I very much would like to just encourage everyone, and we'll keep updating it and adding talks to this webinar series. We give a lot on male incontinence and erectile dysfunction and BPH, and we're going to try to start including some that talk about prostate cancer treatment in general. That's also a very confusing topic for many. And this is my website. This is where you'll find those and other webinars, and I'm hoping you'll learn a lot from my site. I use it very much as an educational tool, very much so. So I'm going to go ahead and click on the Q&A, and I'm going to just start reading these, and I'm just going to try to answer them. Right in the beginning of this talk, the question is, how important is a PSA free fraction? And now we would say that a PSA free fraction is almost useless. But let's answer the question. It's useless because at this point, it doesn't give you any information on if the cancer is significant or not. And the problem with it is it only really tells us if it's a suspicious situation. I call it a bell curve. If you know what standard deviations are, 2 standard deviations from the mean are all the way. So if it's very, very high, it means it's likely just from a enlarged prostate. And if it's very, very low, it means it's likely from cancer. Again, I don't like to get the free fraction because I don't like it to dictate a biopsy when you don't need one. if the free fraction was low, but the PSA was stable, and I find just a little low-grade cancer, it hasn't really helped you. There's a question by the same person that says, is PSA MRI credible? I don't know what a PSA MRI credible is, but I think you might be asking about MRIs. And I think I've probably answered that at this point with what I said about MRI. Here's one that says, is there an age at which I no longer have to be concerned with testing? And I just answered that on the last slide. There is an age where the government guidelines are going to say, let's not test you. But that has more to do with Medicare expenditure and what's good for society in terms of using that same money for something else in the government, if you believe that's how it would be appropriated. But you know, when I'm older, I'll get a PSA here and there. I'll just understand that I'm not going to act upon it unless it ends up being 20 or higher. So that's what I would have to say about that. And then it says, is it true that I don't put much merit in genetic testing of prostate biopsies? Okay, I'm going to go ahead and answer this one, although we're not talking about prostate biopsies. We're talking about PSA testing, okay? And that's kind of a whole other, I could give a whole other lecture on that. What this patient's asking is, okay, you've had a biopsy, and as I already hopefully gave you the impression of, there's a whole industry, a very, very lucrative industry of saying we have this great magic test that's going to say you have an elevated PSA. Let's tell you if it's significant or whether you need a biopsy, which I find worthless. Well, similarly, in my practice, not speaking about other practices, there's also a whole bevy of genetic tests that are very expensive that say you've biopsied a person and you have to decide right now, should you be doing active surveillance or should you be treated? Or there's others that say, should you add radiation or not? And again, I don't find that to be helpful at all because I'm biopsying a very different patient population in my practice. Hopefully you've seen that if you get biopsied in my practice, you already have a very damning PSA rise. So you are very different than the average population that's getting genetic testing. That might be someone who got an MRI when their PSA was 4.9, and then they got what I would consider an unnecessary biopsy. They should be just told to do active surveillance. They don't need a genetic test to know whether that cancer is going to grow. They could just get another PSA in 3 months. And so I do not find that to be important because I usually already have, my patients have already failed active surveillance when I biopsy them. So I usually don't need that type of guidance. But if I was the type of urologist that did over biopsy people and I needed something to give me some guidance as to whether or not someone should be treated, that's probably the urologist that's best suited for. The next question is there an age? No, I'm sorry, I'm missing something. So age adjusted, someone's asking about age adjusted. So age adjusted was a huge revolutionary topic that was fomented by someone named Judd Moll, who was at the NIH at the time and became the chairman at Duke, where he said, look, we're doing all these biopsies. It's ridiculous. Something's wrong here. And it's obvious in our data that the older you are, the higher that cutoff for a biopsy should be. So it wasn't a perfect concept, but it was an understanding that as you get older, your prostate grows, and therefore you have to account for that by saying a bigger prostate, benign tissue makes prostate PSA also. So it was the idea of saying, okay, so for this age, we'll use this number, and this age will rise it. There'll still be cutoffs. We'll still biopsy everybody above that number. So it still wasn't correct, but it was one step closer to saying the earth isn't flat here. And so it was an enormous building block for us to say, we don't need to biopsy everyone at a low number. That's age adjusted. And then the idea here is this next person says, in 10 years, my PSA went from 2.3 to 7.5 with a free fraction that is way out to there. And this person's asking me if they need a biopsy. Well, of course, I can't answer that question because I don't know who it is. I don't know their age. So that's going to be probably best suited to make a telemedicine visit with me and run your parameters. As we talked about, you know, don't know the situation there. So I'm going to hold off on telling you whether you need a biopsy there. If you're asking Does the free fraction suggest that to be benign? Yes. You got an MRI, which means I'm not the one that did it. So I would probably be asking you questions like, who did the MRI? What did they tell you? That kind of thing. So I'm always available for a telemedicine if you have some offline questions that are specific to you. The next question is, for a 40-year-old with a grandfather who died of an aggressive prostate cancer, when should he begin screening? And that's a good question. When should a person begin screening? And that changed when the guidelines changed. So a grandfather, first of all, is not a first-degree relative, okay? So we'll say that this person does have a little higher risk, and I think it's nothing wrong with raising the periscope. 40 these days is probably a little early. We used to say that with a family history. We used to say that if you were African American. I don't think the data supports that anymore, but maybe 45 might be a time. And we know now that if you at 45 get a PSA as a first PSA and it's super low, that you could probably wait a couple of years and not do it every year, that kind of thing. Next question that I see is, how often should you have a PSA test? That's not a generic answer that I could give you. It has to do with how high is it. I just intoned for the previous question, if your guidelines state that if you're getting a first or second PSA and it's really, really low, then that's a situation where you're good for 2 years if you're not in first degree relative. But if it's borderline, then we shorten or lengthen that interval. That's what I do all day. So that one isn't going to be a generic statement. But if it's completely normal, it's usually the generic statement is once a year, but it might be different for you. And then same thing when someone says, how often should it be done after age 75? Again, the guidelines say never. I'd say get it with a physical. And if it's an issue, you talk to a urologist. Someone has asked me to define significant cancers, and I'm hoping I did that with my ultimate slide that talked about what I consider significant. I consider a significant cancer a growing cancer in a patient where the projection would be that that cancer would kill you if untreated in your actuarial lifespan, not necessarily just by Gleason score. Another question, these are great questions. It says, what's the role of a primary care provider versus a urologist in PSA testing and tracking? That's a fantastic question. I think that has just everything to do with the comfort zone of the primary care doctor and their familiarity. I actually was an expert witness in a trial defending a primary care physician who was sued because they did absolutely everything correctly. And I'm thinking I was the witness that won that case for him. There are some fantastic internists downtown here. I'm in downtown DC. I find that many of the internists downtown here that have mostly men my age and men their age, they're so used to this discussion that they tend to do that themselves. I find that internists downtown are very different than internists out in the outer communities, even in Chevy Chase. They will follow the patient themselves, and they will refer a patient when the trend is suspicious. Then there's other internists that the minute it's elevated, they say, I have so many things that I have to follow, which is true, and this whole PSA thing's a changing target. They probably haven't seen a lecture like this, so they find it's more responsible for their patient to let a urologist figure it out. So the answer to your question is it's a function of how comfortable the primary care provider would be following an elevated PSA. I always feel as if it's normal, you don't need to see me. See them and they'll send you to me. That's generally how I practice. They're asking, has recent PSA research been done with good statistical methods? And I'm going to answer that question the following way, and I actually find it to be interesting. There's very, very little research being done to prove that the best way to do all of this is PSA trend. Once MRI enters the picture, there's industry. It's lucrative. All the papers now are on MRI. To me, if I was still in the mode of having fellows and residents, and I've written 23 papers, I would absolutely try to tackle that, but it would be to a very hostile audience in terms of getting it published. I would tackle that by saying, let's look at PSA trend performance versus the performance of prostate MRI as an initial test. But no one really would be funding that. It would be a huge study, easy to do, with conclusions that might not be favorable to those doing it. So I actually, PSA research in the past was the highest power research in the past, and it created this talk. But there's a paucity of PSA research now. Someone says, well, how many tests do you need to have a trend? And that has to do with how high it is. In general, I'm looking for at least 2 in a row, sometimes three in a row, before I offer a biopsy. That's just me. At what point do I use the adjunctive test that I mentioned, such as the PSA density? Well, see, I don't use an actual test. I don't do an ultrasound and say, let's determine this versus this. I do a rectal exam. I know how big your prostate is, so I already in my mind get the sense, and I talk to patients to say, you have a big prostate. We're going to allow you to have a higher PSA, but I don't calculate that number. That was something that people used to do. It's more of a gestalt in my practice now. As I've already said, I really don't use the free PSA, hardly ever. I don't think it's helpful, and I don't ever use the Prostate Health Index. So again, the test that you're mentioning, this questioner, you're mentioning tests that are designed to be adjunctive to a single data point. We have an elevation. We need to know, is it suspicious or not? And those are out, in my opinion, completely outdated measurements that do not talk about in any way, shape, or form the significance of cancer. So you ask, would they be used in active surveillance? No, because active surveillance is all about determining whether the cancer is growing. So I would never be using those. There are others that might use those others I mentioned, 4K, Select MDX, ExoDX. Again, the trend for me is way, way, way more predictive and less expensive. And what percentage of cases would be missed in active surveillance if we only use PSA alone? Well, again, I guess what I could say is it hasn't happened to me yet. I've been doing it for 23 years, probably in 10,000 cases. There might be a case at some point that's a 1 in a million, and they would be missed by the other tests. But the better question, because again, if the PSA is what got you biopsied, that means we're already trying to accept the fact that the PSA is elevated because of cancer. If we're going to accept that fact, then you would have to accept the idea that if that cancer was going to kill me, then it needs to grow some first. That's what happens. So if that PSA that got you biopsied was worth following, then you have to say, then if it's worth treating or if it's growing, then the PSA will rise. So I actually would argue, what percentage of cases are going to be missed in this circumstance where you're just following a guy with a PSA closely? The same amount that would be missed. The better question would be, what percentage of cases am I not going to overtreat because I'm not doing these tests that are going to falsely identify people and get them treated a lot? That's why I do it the way I do it. I'm trying to keep people from being overtreated. At least I'm doing my best. Someone asks, what PSA values constitute aggressive cancer? Well, that's not it's not a perfect question. Aggressive cancer has to do with a trend. So again, that's a case-by-case basis. So it's not an absolute number, it's a trend. What nutritional supplements would be beneficial to lower or retard the onset of prostate cancer? Okay, that's a great question. And here's my answer to that. This person has mentioned lycopene and turmeric. Lycopene is a tomato extract. The problem with most all of these natural remedies is that there will be a study that might suggest that there's a little bit of evidence that it does something. Lycopene is a great example. Lycopene extract, you'd have to eat like 100 tomatoes. They're going to concentrate it up and put it in a pill. And they showed that in some patients, the PSA went down a little tiny bit transiently and then went back up. So that meant it was studied, it was looked at, but it doesn't mean it does anything for you. But in the herbal world, from that point on, they're going to say lycopene is good for your prostate. And that's the problem, because those are food supplements that don't require FDA approval. Similar situation for turmeric. The best example I can remember is when they said that oatmeal was good for your heart in a big study, and Quaker Oats still has the heart on there. And all that was they noticed that people that ate oatmeal with blueberries or something in it in the morning did better than people that had sausage McMuffin with egg every morning. You know, was it oats, or was it just that they weren't eating sausage McMuffins, which are addictive and probably my favorite sandwich, but I don't eat them? And the answer was no, it's obviously not the oats, and they proved that it wasn't the oats. But from that point on, Quaker Oats says it's good for your heart. So general dietary recommendations for all cancers and everything is to be healthy, don't be obese, and work out and be healthy. And I try to ascribe to that myself. If you're healthy, your body can then work better as a machine. And if your body can work better as a machine, it can fight disease within it better. And so that's the better recommendation. I'm going to keep going here. A lot of questions. I'm going to just see if I can get to the bottom of them. And this one is asking me specifically what kind of trends worry me. And again, that's too generic a question. It's a case-by-case situation. As you might know by now, it has to do with age and things like that. Can a digital rectal exam catch cancers? Yes. And so certainly at least once in your screening process, you need to have a rectal exam. When someone's new to me, they're going to need a rectal exam. Do I do a rectal exam every time? No, I do not. If you had an initial rectal exam that's normal and your PSA stays stable, I've never seen anyone develop a terrible nodule or terrible cancer with a stable PSA. So I'm going to do rectal exams when I'm on the verge of wondering, should I biopsy or not? But a rectal exam should be a part of screening. So particularly when it's abnormal. How do you suggest I talk to your primary care physician about your concerns about prostate cancer risks? Well, I guess that question, you should just say, are you screening me for prostate cancer? There is the rare person that still says, I'm not going to screen you. That's why I mentioned that guideline era. The guidelines are now to be screened. And if you say, I'd like you to screen me, ask them to screen you. If you're getting an argument about that, I would question that person a lot. There's a person that says you're 50, you've never had a PSA test, and you haven't really had a good reason to see a doctor about your prostate. And should you schedule a PSA test? Well, you should just say at some point, I'm going to get a physical. And if you've had a physical, and it's not an emergency, and it doesn't have to be at this moment, but if you've had a physical, okay, then they've done your PSA, actually. They probably just didn't mention it to you. When I was 50 and I'm about to have all these tests again, and I should go to the doctor more, but I had a physical and a colonoscopy and all that stuff. So maybe that's where you are. But if you get a physical, it's going to be part of a standard physical. Now I have someone re-asking, giving me all of his specifics, but I'm not going to kind of answer specifics. That one's going to be a telemedicine one. I'm happy to kind of guide you on that, but I need that to be more of a doctor-patient relationship thing. How is a transrectal biopsy done? Well, first of all, I know that I wrote up how that's done, and it's now, it didn't used to be, but it is now on my website. But it's a 6-minute, so if you want it in great detail, it's right there. It's a 6-minute procedure in my office. For me, it's always in my office. You're going to find that a lot of urologists these days belong to big groups where they own surgery centers, so they try to do everything there. But it's a very easy thing. You're wide awake. It's 6 minutes. I put a little small probe in your rear end, which is an ultrasound probe, and then I numb your prostate, and then I take pieces. It doesn't hurt. It's quick and simple. You walk out, and I know the result 2 or 3 days later. This person is asking whether finasteride or Propecia, that's the same drug at a lower dose that's for growing hair. Finasteride is to shrink the prostate. Does it make PSA testing and monitoring ineffective? No. It will reduce one's PSA very predictably by 50%. So if I see someone on finasteride and they have a PSA of 2, it's really 4. If it's 4, it's really 8. That's the general rule. Rising PSA on finasteride is a very suspicious situation. That one is usually something that gets me to biopsy. Why so much emphasis in avoiding a biopsy? That is a really, really good question, because you heard me say, I just told you, it's 6 minutes, it's easy, it's no big deal. Infections can happen, but they're really, 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 really rare. So that's something I'd like to answer. Why do I try to keep my patients from a biopsy? I talk about, I'm going to watch you without a biopsy. And the answer is the following. If I do a biopsy and I find that it's normal, yay, you're happy and you have peace of mind. This is the same discussion with MRI. Patients ask for MRIs because they're hoping it's normal, but then they're sorry when they did it and it's abnormal. If I do a biopsy on a patient, let's pretend the PSA is 4.6, and I wasn't ready to do a biopsy. I would have seen what the next one showed, but I did it at 4.6. Well, almost by definition, so if I find cancer then, so if I find a more aggressive cancer that I have to treat, great. But I would have found that patient 2 or 3 months later with PSA when it was 5.6. We consider cases early less than 10. It wouldn't have put that patient in harm's way, and I would have still found it. However, if I biopsy that patient when it's 4.6 and I find it to be a little bit of low-grade cancer, now, even if the PSA goes down on the next one to 4.8, in which case then I might see that patient in 4 months. And then if it's 4.8, I might see them in 6 months. And then if it's 4.8, I might see them in 1 year. And they're not worried, and they're not worried about anything. And they're not going to go get treated. It's going to set my patient off on a journey of worry. And if they see the wrong doctor, overtreatment, they're going to see an ad for a special magic radiation on a bus and go get it, or get treated when they don't need it, or have worry and anxiety and have to follow me every 3 months for the rest of their life at that point. That's not helping that person. That's harming that person. And that's why the biopsy is avoided until you need it in my practice. Because I know that patient is not helped by getting a biopsy too early. So does caffeine raise PSA levels? Generally not. How often should a patient with an enlarged prostate have the PSA test? Well, that, one has nothing to do with the other. How often has more to do with what's the number and how closely do you have to be watched. And enlarged prostate patients will have a higher PSA. But once I establish that the plane's going to level out at a higher number, then I back off and off and off. So it's not a one-size-fits-all answer to that question. We've already talked about how finasteride affects the PSA number. And then it says to certain races, countries, continents, etc., have prostates that tend to grow larger. I don't know the answer to that question. I don't know if anyone's ever done that study, right? They've tried to do some racial studies that African Americans were felt to have worse prostate cancer. That may or may not be true. It's probably not African Americans. It's that obesity tends to have, in general, more cancers across the board, and there's more obesity in that population. But I don't know about prostate size. So that one, that's the first one. Unfortunately, I've said I'm not sure about that. I know the patient that's asking me that question, and I know, for instance, that they have a very high PSA, and we followed him, and we've done a saturation biopsy. And there's an example of a man with a PSA that's 20 or 30, and we're going to consider him normal. It just is what it is. That's an example there. Here is somebody that is asking me very, very specific questions. Used to see my old partner, Mike Phillips, about his case. That's going to be, I'm going to very much invite you to discuss that with an appointment with me. That's kind of more of a, why don't you become my patient, and I'm more than happy to help you there. We talked about a family history and the question of an uncle or a brother being a first-degree relative. A brother is, an uncle isn't. And just a quick discussion of family history. Now, hopefully, there's still 52 brave souls that have still stuck around this long, and I'm flattered that you have. Family history. Patient will come in and say, my father had prostate cancer. And unfortunately, hopefully by now you've learned that we went through a period of rampant overtreatment and overdiagnosis. So I actually don't really know what to make of that unless I know the details of the family relative. If somebody says, so if they say, but my brother had his prostate removed, I don't know if that's somebody who was overtreated or overdiagnosed. But if somebody says, my brother died of prostate cancer, or my father died, or either of them are getting hormone therapy because they have metastatic, now we know that's a very significant cancer, and that's a family history. And then what does it mean if your PSA count jumps up but then drops down? So I think a better way to ask that question is, what does a trend of a bouncing PSA mean? And generally what that means is just that you're getting older and your prostate's growing, and that's just the trend we see. We don't know why, but it's just a trend that we see. But it tends to not mean that you have prostate cancer growing and growing and growing and growing. That's just an upwards trend. So if I can show a bouncing pattern, I usually hold off on a biopsy at that point. Again, people are asking me what's an aggressive trend and are there any tables that show this? No, there isn't. And it's just impossible to show that. And that's partly the problem of why the government just really doesn't like talking about PSA as a trend test, because it's not regulatable. It's not a guideline-based thing. So again, you're asking what trend would be a problem, and that's going to have to do with how big is your prostate, what's going on here. Certainly, lots of things can raise your PSA. We didn't talk about that. Enlarged prostate, I keep talking about that. Inflammation or infection can too. So, I will say that a trend is not 1 point and a trend is not 2 points. A trend statistically is 3 points, which is why I'm going to look for 3 or 4 points before I say you need a biopsy. How much is PSA affected by recent ejaculation? A rectal exam immediately before the blood sample? Well, or exercise. I would, hopefully people are, understanding that I have an office here near DuPont Circle. So we would also say, what about anal sex, receptive anal sex, all that kind of stuff? And the answer is, it certainly could be. I think a regular rectal exam that I'm going to do is not going to affect that. But if you just ejaculated or ejaculated several times, people will say riding a bike, those kinds of things, that very much can affect it. But again, if you're ascribing to the notion of using it as a trend and you're just living your life, and that means ejaculating once a day, or that means riding your bike to work every day like me, then we're only looking for a trend, and the constancy, all those different things will sort of go out of the mix. If I'm on the verge of biopsying someone and someone says, yeah, but I just ejaculated, or let me try again, and I'm not going to ejaculate, and I'm not going to ride a bike, I say, absolutely, let's see. And that may or may not be involved. But most of those things where we very much made a point of that were back in the day where you come in with a PSA of 4.2, and we would want to have a reason why it's okay to repeat it again. And we were told we can't, we have to biopsy you. Well, these were excuses that allowed us to repeat your PSA again. It's why it doesn't come up too much in my practice, because I use it as a trend. People are saying, at what PSA is catching prostate cancer early? We generally consider a case being caught early when your PSA is less than 10. Less than 10. So again, you come and see me and your PSA is 4.6. I absolutely know that if I just wait a little bit for that PSA to keep rising, the system's working and I'm catching you. And so that's a very important question you've asked, and it's a very important answer I've given you. It's the basis of saying, let's see what the next one shows. And what's a normal annual increase in PSA? Well, when you get to probably around my age, that first paper I mentioned in this talk from Columbia University that mentioned PSA velocity, they defined normal to be less than 0.75 per year and abnormal to be greater than 0.75 per year, sustained with several data points over 2 years. So if you actually, I don't ever even think about that, but if you think about what I've said, who gets biopsied, I was actually basically describing somebody who's having that type of sustained rise of, within 2 years of seeing it go, at least 1.5 to 2 up. That's a good way to answer it, is that PSA velocity question, a normal increase is, it doesn't have to be less than 0.75, but a slow drift normal, a fast rise abnormal. Okay, that gets me to the end. The last question was asking again, should a person not ejaculate the day before getting the PSA? And the answer is, well, nothing wrong with doing that. You want to get an A on the test. So those are all the questions we have. We had 39 questions. I think I answered most of them. And thank you so much for staying with me. Look for other talks on my site. I'm going to keep expanding this. Look for those emailed invitations. And thank you for joining me. I'm going to figure out how to stop recording. And anyone who needs to talk to me further, let's just make an appointment. I'm happy to see you in my office, and go to my website.